Since 2009, Brandon Sturgill, our first presenter, has served in the capacity of hearing and appeal coordinator for PASAR in the division, for the PASAR division of the Ohio Mental Health and Addiction Services. He's a member of National Association of PASAR Professionals since 2012 and was just recently elected to the board of directors of NAP in 2014. He provides PASAR training, outreach, and technical assistance to state agencies, nursing facilities, hospitals, legal guardians, and individuals diagnosed with mental illness. Jeff Ryan is a clinical supervisor and assistant chief of the PASAR division of the Ohio Mental Health and Addiction Services. Jeff provides technical guidance to staff, internal and external stakeholders. Jeff completed his BS degree in psychology and earned a master's degree in social work at Ohio State University. Jeff has professional experience as a case manager, psychotherapist, and program administrator in mental health and substance abuse. Adrena Tart is also from Ohio, is currently employed at the Department of Mental Health and Addiction Services, as Special Populations Coordinator for veterans and older adults. She represents the department on several statewide committees: Ohio Cares, which is a system collaborative with Ohio National Guard and other relevant stakeholders addressing behavioral health for service members, veterans, and their families; the Ohio Brain Injury Advisory Committee; the Elder Abuse Commission; the Supreme Court on Adult Guardianship Committee; and the Ohio Advisory Council for the Aging. Ms. Tart is a United States Marine Corps veteran, holds a Master of Arts degree in Alcohol and Drug Abuse Ministries from the Methodist Theological School in 1993, and a bachelor's degree in social psychology from Park College, 1990. She's a licensed independent chemical dependency counselor and social worker in the state of Ohio. Adrena has recently joined us as the OPD rep for the state of Ohio, and we want to welcome our next presenters. Come on up. Do you want to run your own slides, or do you want me to? No, I'd be happy to. Yeah, okay. Okay.
Good morning, everyone. Let's go ahead
This one first?
and bring up the one page.
You want
Can you do
okay.
that first?
Yeah. Okay.
And then I'll give a kind of an overview, and then we'll jump into the
Okay.
So today's presentation is from the perspective of our department, the Department of Mental Health and Addiction Services. We're going to show you guys essentially what we believe to be a best practice. It's a pretty lofty overview, and we'll work through it. So the one pager that you guys should have, and I guess if I could take a step back, and I don't know if everybody's been able to get a copy of the presentation, a copy of the one pager. It's a wonderful turnout. We didn't really anticipate more than 40 folks here, so I kind of reluctantly apologize that you don't have them. And what we'll do is present our contact information at the end. If you're interested, you can email us. They'll be on the NAP website as well, which is www.pasar.org, so you can view all these there. The one-page document that we've got is going to show how we bridge the gap. So in effect, we have an individual in a nursing facility setting that seeks to return to the community, and the question that we ask is essentially, how do we make that happen? So you could jump, Lila, to the presentation. This will make a lot more sense, I think, when we get to the end of our content, and then we can take some time to address that. So in effect, what I had introduced before is how we collectively work to achieve this task. I've heard a lot of great things from Frank. He laid the groundwork. I've heard money follows person. I've heard person-centered discharge planning activities. We've talked about balancing incentives and a bunch of good things that will dovetail into this. So I don't necessarily want to belabor the point. You guys are going to be presented with plenty of stats today. I think the nature of this conference should suffice to say that we all know that we have a population that is increasing rapidly of the older adults, and also what we know is that we have a known prevalence of mental health related conditions across populations. If we look at NAMI, for example, when we say, okay, well, a quarter of the population has some diagnosable mental health condition, and we apply it to this population, we can kind of start to explore the difficulties that we're going to have as things do gear up here, and we've really got to begin to address this issue. You can go ahead. A lot of what we've done, and this perspective again is from the state designated authority on mental health, lies in relationship building. So there's a couple of things that we've done to make sure that we've got some solid relationships with some relevant stakeholders. You'll see some of the examples would be, providing training, technical assistance, deliver presentations as subject matter experts. We network a lot, we collaborate a lot, we volunteer our resources, and we always have a seat at the table. So these are some of the things that we've, I guess for lack of a better word, self-imposed. And you'll see what happens, I think, as we get through the content here of what the end result actually is when we start with a foundation of building relationships. There's one thing that I wanted to touch on, just to give another example, and we've talked about money follows a person. So what we specifically have done in our department is create a liaison, or have liaison position. So we have an individual that sits at Ohio Mental Health and Addiction Services who acts in the capacity of a liaison to our Money Follows a Person program, which sits under our state Medicaid agency.
I have to take a picture, sorry.
Oh, wonderful.
I forgot that as of yesterday I was given this assignment to take some pictures during this presentation, and I was like, oh wait, I haven't done that yet. So sorry.
Yeah. No, it's fitting because this is actually the first presentation that I've done where my boss is in the front row and he's recording this.
Okay.
Good. Some of the agencies that...
Well, you're smiling, Brandon, so that's good.
No, it's good. We're lighthearted here. Let's go back one more slide.
Go back? Okay.
Yeah, and talk about that for a second. I want to let Jeff and Adrena talk about how they collaborate. So across agencies, this is a really comprehensive picture. But just to lead into the discussion, some of the things that I do is collaborate with a lot of nursing facilities. I provide a lot of technical assistance and develop those relationships through technical assistance calls. I in a couple of instances, given presentations through our statewide hospital associations. So we get to answer a lot of questions, dispel a lot of myths, and build on a relationship that's pretty reciprocal in that nature. One of the things, I guess, Adrena, you want to come up and talk about, and Jeff too, the Medicaid Money Follows a Person implementation agency. So I'll step back and let you guys talk a little bit about how you interact with some of these agencies as well.
Basically, with the state Medicaid, we're involved in the interagency work groups in which we're kind of talking about certainly long-term care and the level of care in long-term care. With Money Follows a Person, it's kind of intimately related with when we have people who we have passed our reviews we're doing, in which we want somebody to kind of maybe they will be in there for a short amount of time in the nursing facility, and we work with Money Follows a Person to kind of help create a transition plan for them to come out, and then the state aging authorities basically to kind of because we're kind of on the same team and kind of coordinating on various kind of issues as things have changed. We had a change with our the use of the hospital exemption of folks out of psych units, and we don't allow that in the state anymore. And there's a lot of coordination changes we've had to kind of do with community mental health boards in conjunction with other positions in our Bureau of Community Options. If we have somebody who is, it could be the community health board, mental health boards, and disability rights, which is like legal rights, in which you actually might have somebody who's calling and contacting, say, legal rights, that they want to get out, they want to transfer start to kind of, we work with our community options persons. We have somebody who's involved with recovery requires a community, which is kind of a funder of last resort. I mean, both of those two individuals, George Pelletier and Adam Anderson, are going to be speaking tomorrow at 3 o'clock in nursing facilities in transition. A lot of involvement with them, and certainly some technical assistance with nursing homes when they're calling in. I think the long-term care ombudsman, obviously, we have some of the issues that happen when you have somebody who went on a significant change from a nursing home to a psych unit, and the nursing home doesn't want to let them back in like that. We involve the long-term care ombudsman to kind of help advocate the transition to back in. But we definitely, we need each other as a team. That's kind of from what I see, what I do.
So, our community behavioral health authorities, we are a home rule state, and we have 53 community behavioral health agencies across the state of 88 counties. So it's a home rule state, and they control the local planning for our alcohol and drug and behavioral health system. And we have partnerships with the local level all across the state. And we make sure that folks are sitting at the table, as well as our AAAs. We have 12 AAAs in the state. And we make sure that we're embedded. I like that word, embedded, because that's the way you forge those relationships, and you learn each other's systems, and you begin to just learn each other and how to access certain providers and so forth. And so I think that this collaboration across agencies, state and local communities are very critical in terms of making things happen for older adults and caregivers and their families.
Let's move forward, and I think that's a good overview, of kind of the collaboration. So we'll see the end result as we progress here. So one of the things that we won't spend a whole lot of time on are some results that you'll see associated with our Money Follows the Person program. I don't know if Jane's in the room or not. Jane's here. Jane Black she sits at Medicaid. She's a manager for the Money Follows the Person program, and through her team's effort, she's been able to place the state of Ohio first in the nation in transitioning individuals from institution settings to community for the individuals diagnosed with mental illness, and her team's got a second in the nation for all disability types, and then sixth in older adults. And I'm sure she'd entertain some questions about the things that she's done across her team to actually make that happen, because there is quite a bit behind the scenes there. Let's go ahead and we'll move forward, Lila. Frank mentioned balancing incentives. I'm sure you guys have probably heard of it. If not, you'll probably do some homework on it. It's a pretty interesting concept and a program. It's simple at its roots, but it achieves some very complex things. I just want to stress that it's on the horizon. So the balancing incentives for Ohio, I think that our target date's mid-2015. Jeff works in collaboration with the state Medicaid agency and attends quite a bit of their meetings. He's got an IT background, so he works on that component. If you could give some nuts and bolts of kind of the things that we do associated with balancing incentives, the overview, how the program works.
Currently, what we're doing, we have just, there's a portion of it in which you have websites in which someone looking for long-term supports and services will be able to kind of access and kind of see what's available, 1-800 phone number. The thing we're going through this period, we had a request for RFQ that went out. Medicaid selected the vendors, and it'll be for the IT infrastructure, but the kind of the cool thing I think with it would be that we're gonna kind of coordinate all 4 different departments, Department of Medicaid, Department of Aging, Department of Developmental Disabilities, and the Ohio Department of Mental Health and Addiction Services, in which you'll have all these processes occurring at the same time instead of what was happening before. We did a Kaizen, which is kind of a quality kind of thing for a week. There are like 350 steps, and we kind of were able to work it down to 50, in which you would get, essentially you would have, if somebody creates an account and really is interested in following up on long-term supports and services through some kind of maybe nursing facility or some other kind of waiver, the systems for getting them to see if they're eligible for Medicaid, to kind of connect them with mental health and ED, and having it all occur at the same time. There is a part on the mental health in which our department also kind of helped give input on various kinds of screening tools for, say, if someone has some mental health issue. There would be a mechanism, since we wanted it to be face-to-face, that it would go out to the agency, and then they would set up an intake, and then we'd get some feedback that would inform care like that. So it's on the horizon, but we've got a lot of energy and kind of working with it, and I think it's kind of exciting.
Yeah. Let's go on to the next slide. I heard the first presenters talk about Olmsted initiatives, and I was kind of glad that they did so, because it's a really important area to focus. I'm sure everybody's familiar with Olmsted, if not from the first presenters' remarks, through your own experiences. The Olmsted initiatives in Ohio are achieved through a couple of our divisions. If we're talking about Department of Mental Health or the State Mental Health Authority, one of the things that we've adopted through our relationship building is what's termed as an Olmsted assessment. So it's a unique type of assessment. Frank talked about briefly the need to get some type of an in-person assessment to get a licensed mental health clinician in front of an individual to thoroughly assess their needs, to get some clinical recommendations. Now, some of the other relationships that we talked about, the collaboration through our legal rights advocacy groups, perhaps bring these to our attention. So in the instance we have an individual that seeks to return to the community, we would go essentially above and beyond anything we're required to do. This is more or less self-imposed. We'll say, okay, we're going to volunteer what we have, and we're going to perform one of these assessments for you. So for the individual, what we would do is send out a licensed mental health clinician to interview the individual, gather information, and then we take it back in-house, and Jeff and his folks are the ones that would actually look at this information and then make some clinical recommendations. So you can go ahead, Lila, to the next slide, and I'll let Jeff jump in here. But essentially the point is to take ownership of the case or the situation, which we've done. And as I stated before, when we go out and we do these assessments at the request of either the individual or some other entity that advocates on their behalf, there's a process that's taken us a couple of years to develop here. But we've got it down pretty good. And Jeff, maybe you can give an overview of kind of how our processes work.
Basically, what we're doing is we have the way it started initially was that we would have these reports. You have somebody who has an interest, and they can say we had no other prior information on it. So we thought it made sense to kind of have one of our assessors go out. There wouldn't be any threat of determination with that, but it'd be more of just kind of giving them the opinion. With this individual, I mean, do they require the services provided in a nursing facility? What is, what are they, how is their life going? What kind of, is there community support for them? And just to kind of have a clinical review of that. And then tonight, and essentially we get it from Disability Rights Ohio, usually often calls us in with that, and then we send out someone to do the assessment, and then that person sends us in a report. We take a look at that and kind of make, it's just whatever. whatever the, just to kind of see, is it possible for this person to go in the community? I've had some in which, yeah, it looks like the only reason they're there is for behavioral management. Other times, of what I know of a rural community where they're at and all, it looks like they're in the best place. But they have that information, we can hand it back. If the guardian still wants them in the nursing facility, even though they don't really, that's up to them to kind of take that next. But at least give some kind of clinical eyes on it, which I think that's very helpful. And kind of just keep all the players in the mix.
Yeah, and you guys, if you're here tomorrow, we've got a couple folks that are going to present. These guys are doing some pretty innovative things, and that's the coordinated activities of coaching. And we can always talk about that a little bit more, after we're done here. If you guys have questions, we'll be glad to address them. Let's go ahead. I think we're okay with this one. Let's go to the last slide and turn it over to Adrena. So after the transition, these are some important things to consider. I'll let Adrena tell you from her perspective after we get to this point, some post-transition issues.
So just to put a little context into the post-transition, the leadership of the state has worked very, very hard doing some state reforms to try to ensure that we have partners and key stakeholders that are bought in and that can really ensure the quality of services for older adults and individuals with disabilities. So we started working from some shared guiding principles, and these principles, one of which were to enable older adults and people with disabilities to live with dignity in their preferred setting, in specifically their home environment, and also to ensure that they had a voice in directing that where that would be, and also looking at primary care as health promotion instead of a illness type of system of care. So with those two guiding principles as it relates to older adults and people with disabilities, we really began to engage across systems, leveraging resources within the state, and we had partners that normally wouldn't be at the table join us at the table. We were able to look at issues as it relates to what actually are the resources, in particular rural communities versus urban settings and so forth. Where are the gaps? So issues like with housing, we could look at one size doesn't fit all. So we looked at developing an array of housing. And the state has this group called the Interagency Homelessness and Housing Group that looks at all of the housing stock and able to communicate across state agencies, because at that particular body, various state agencies sit. So just really beginning to leverage resources in multiple ways. The ADRN is being initiated in various local communities, bringing providers together, creating MOUs, and really trying to ensure a streamless system for older adults and making sure that they have a quality of care. You'll be hearing more about the Recovery Requires a Community tomorrow, and money follows the person. One of the things that I wanted to highlight is from the primary care side, we were awarded an SBIRT grant from SAMHSA for $10 million that looked at doing some of those alcohol and drug screens and depression screens in primary care, and looking at training a variety of providers, even military veterans, medical personnel, as well as some other medical school constituencies and so forth, trying to just bring people together and move them forward in working with this particular population. We also are still using Healthy Ideas and really plan on broadening that reach as well.